Welcome to the Deep Dive, the place where we cut through the noise and get straight to the critical knowledge you need.
Mm-hmm.
Today, we're diving into a topic that is just fundamental to surgical care. Intravenous fluid therapy.
Yeah.
It's a field where management can shift so quickly from, established protocol to these individualized minute-by-minute decisions.
It really can.
Our sources for this deep dive are comprehensive excerpts from a key medical text, a 2018 CRC press book. It pulls together decades of research on fluids, electrolytes, and hemodynamics in really complex surgical settings.
And our mission today is really for you, the medical student or professional listening. We want to give you a shortcut to the most crucial evidence-based principles.
Okay.
So you can stop seeing IV fluids as just, volume and start treating them like the powerful drugs they are, with real mechanisms and real side effects.
Let's do it. Okay, let's start with the basic architecture, the foundational science. We have the major fluid spaces.
Right. You got intracellular fluid, the ICF, so what's inside the cells.
And then extracellular, ECF, everything outside.
Exactly.
Yeah.
And the boundary is the cell membrane. But if you want the one governing rule for macrofluid balance, it's this. The total amount of sodium in the body is what determines your ECF volume.
Water just follows the salt.
Water follows the salt to maintain tonicity, yeah. So if you can control total body sodium, you control the ECF volume. It's that direct.
So for over 100 years, our understanding of how fluid actually moves across that capillary wall was based on Ernest Starling's principles, right? From 1896.
Right, the classic model.
The idea that hydrostatic pressure pushes fluid out and then colloid osmotic pressure, or COP, from plasma proteins pulls it back in.
That model is a great starting point, but we now know it's, it's way too simplistic. And this is where it gets really, really interesting for clinical practice.
Okay.
The real gatekeeper isn't just the vessel wall. It's the endothelial glycocalyx, the EG.
The glycocalyx. I hear about this constantly now. Can you kind of paint a picture of what this actually is?
Absolutely. Think of it like a dense, very delicate sponge that lines the inside of every single blood vessel. It's made of proteoglycans and glycoproteins.
A sponge.
And its job is essential. It physically traps plasma proteins, especially albumin, right up against the vessel wall.
So wait, the primary barrier isn't the capillary wall itself, but this fragile layer on the...
Precisely. This creates a tiny protein-poor space right under the glycocalyx. So the powerful osmotic gradient that keeps fluid in the vessel is actually between the protein-rich plasma above the glycocalyx and the protein-poor fluid below it.
I see.
When that sponge gets damaged by surgical stress, inflammation, reperfusion injury, or even just slamming in fluid too fast, it breaks down.
And then what happens?
Capillary permeability just skyrockets. You lose that gradient, and you get massive fluid leakage into the tissues. You get edema. This revised Starling principle is everything for modern fluid choice.
Okay, with the glycocalyx in mind, let's talk about the fluids themselves. The bags we hang, we have crystalloids, the electrolyte solutions, and colloids.
And we have to start with the big one. Isotonic sodium chloride. 0.9% saline.
Normal saline.
Yeah, but that name's a paradox, isn't it? We call it normal or physiological, but its chloride concentration is 154 millimoles per liter.
Which is way higher than our own plasma.
Way higher. Our plasma is around 95 to 105, so it's not physiological at all.
And dumping all that extra chloride into a patient, that has real consequences.
It leads directly to hyperchloremic acidosis. And to get this, we have to briefly touch on the strong ion difference, or SID.
Okay, SID, for a learner, can you just break that down? Why does adding chloride, which is an anion, make the patient acidic?
Great question. The SID is just the difference between your strong positive ions like sodium and your strong negative ions like chloride.
Okay.
When you infuse normal saline, which has an SID of 0, you're massively increasing the body's chloride load. This shrinks the overall SID of the blood, and chemically that forces bicarbonate levels to drop.
And lower bicarb means acidosis.
Exactly, a metabolic acidosis.
And the sources also say high chloride is directly toxic to the kidneys.
Correct. It induces renal vasoconstriction. It literally clamps down on the blood vessels in the kidneys, which reduces blood flow and drops the glomerular filtration rate.
Which is why we're seeing this big shift towards so-called balanced solutions.
Yes. Things like Ringer's lactate or Hartmann's and Plasmolite. They're designed to fix this exact problem.
How do they do that?
They just replace a lot of that chloride with metabolizable anions, lactate, or acetate. So Ringer's has a much more normal chloride level, around 110. And when the liver metabolizes lactate, it actually helps generate bicarbonate, which buffers the pH.
Okay, let's move to colloids. Albumin is the natural one, right? It provides most of our plasma cop.
It does, up to 80%. But there's a risk, especially in really sick patients with leaky capillaries like trauma or sepsis.
What's the risk?
We call it albumin trapping. The barrier is so damaged that even big albumin molecules leak out. Once they're in the tissues, they exert their osmotic pull there, dragging even more fluid out of the vessels and making edema worse.
And then there's the big controversy over synthetic colloids, hydroxyethyl starch, or HES.
Yeah, every medical professional needs to be aware of this.
Yeah.
HES was used for years for rapid volume expansion.
But the safety data caught up with it.
It really did. In critically ill patients, especially with sepsis, HES is clearly linked to nephrotoxicity, kidney damage.
And that's why you see these huge black box warnings on them now.
Exactly, which has basically forced us to favor balanced crystalloids and, if needed, albumin.
Okay, let's talk about the volume itself. We have to talk about the old and thankfully mostly discredited idea of the third space.
The third space. The idea was that during big surgeries, massive amounts of fluid were just lost, sequestered into some unseen, unusable space.
A hypothesis that led to a pretty dangerous practice.
It led directly to the historical practice of liberal crystalloid infusions. Clinicians thought they had to pump in huge volumes to replace these so-called unmeasured losses.
And the clinical reality of that was not good.
It was detrimental. You'd have postoperative patients retaining 7 to 10 liters of excess fluid.
10 liters?
Yeah. It led to gut dysfunction, poor wound healing, and most critically, severe pulmonary edema. The complications were so bad, it forced a major strategic pivot.
And that pivot is the restrictive versus liberal debate. Now, restrictive strategies are generally the way to go for major surgery, like a colorectal resection.
That's right, and we have data. In lung resections, for example, giving more than 6 mils per kilo per hour of crystalloid was clearly linked to more pulmonary complications.
But, and this is a key nuance, it's not always restrictive.
No, for minor or ambulatory surgery like a routine lap col, a slightly more liberal approach can actually be better, maybe 20 to 40 mils per kilo total.
And that helps with what?
It's been shown to reduce post-op nausea and vomiting, PONV, and even improve early recovery markers like exercise capacity.
So there's no single rule, which brings us to the modern solution. Goal-directed fluid therapy, GDT.
GDT is the core of modern practice. It's pure individualization. You give a fluid bolus, not because a protocol tells you to, but because you have quantitative monitoring that proves the patient will actually respond.
By increasing their stroke volume or cardiac output.
Exactly. And if they're not responsive, more fluid isn't therapy anymore. It's just harm.
So using GDT means we have to abandon some of those old, unreliable markers. I'm talking about CVP, heart rate, blood pressure.
This is a huge takeaway for anyone learning this. Central venous pressure, CVP, is still used as a measure of preload or volume. The evidence is clear. It just doesn't correlate reliably with perfusion or volume status. Same for a static blood pressure reading.
We need dynamic indicators instead, things that track changes across the breath. Tell us about PPV and SVV.
Pulse pressure variation and stroke volume variation. They track the changes caused by a mechanical ventilator.
How does that work?
When a patient is fluid responsive, their cardiac output swings with each positive pressure breath. A PPV of, say, 10 to 13% or more is a strong signal that giving fluid will increase their stroke volume.
That 10% threshold seems almost too neat. What are the biggest traps when you're relying on PPV?
The trap is context. It only works in a very specific situation. The patient has to be mechanically ventilated with a decent tidal volume and critically no spontaneous breathing. If they're taking their own breaths or if their chest is open, PPV is totally unreliable.
Got it. For semi-invasive monitoring, the esophageal Doppler monitor, EDM, has been a real game changer.
EDM is fantastic.
Okay.
You place a probe in the esophagus and it measures blood velocity in the descending aorta to estimate cardiac output.
And the evidence for it is solid.
Very solid. Using EDM to guide fluid therapy has been shown to reduce hospital length of stay by a mean of 3.7 days. That's a huge impact on patient recovery.
A massive metric. But you mentioned earlier we need to look beyond just bulk flow. We need to think about diffusion. That's where microcirculation monitoring comes in.
Yes. Systemic flow, that's convective transport. It gets oxygen near the cells.
But not in the cells.
Right. Diffusion is what gets it in. Microcirculatory monitoring, like assessing total vessel density or TVD, actually looks at that final step. And what's fascinating is that the microcirculation can be failing even when your systemic numbers, your blood pressure, your cardiac output look perfect.
So you can have a great blood pressure, but your tissues are still suffocating.
Precisely.
Let's shift these ideas to some high-stakes environments. Let's start with trauma. We're fighting that lethal triad: coagulopathy, acidosis, and hypothermia.
And that fight is all about damage control resuscitation, or DCR. The absolute cornerstone of DCR is the minimization of crystalloids.
Why is that?
Because aggressive crystalloids make every part of the lethal triad worse. They cause hemodilution, which worsens coagulopathy. They're cold, which worsens hypothermia. And they can lead to deadly complications like abdominal compartment syndrome.
So instead of crystalloid volume, modern protocols are all about blood products.
Exactly. High ratios of plasma and platelets to red cells, ideally 1:1 to 1.
And that helps with?
It achieves hemostasis much faster and dramatically improves survival. And remember that plasma benefit. It's not just clotting factors. It actually helps repair that damaged endothelial glycocalyx we talked about.
Okay, last special population, pediatrics. The physiology is so different.
Immensely different. Infants are 75 to 80% total body water. Their maintenance needs are calculated differently, using the 4-2-1 rule.
4-2-1 rule. Remind us of that.
It's 4 mils per kilo per hour for the first 10 kilos of body weight, 2 mils per kilo for the next 10, and 1 mil per kilo for every kilo after that.
Right.
But the number one critical risk in children is iatrogenic hyponatremia, low sodium caused by us.
Why are they so susceptible?
Surgical stress causes a massive surge of ADH, antidiuretic hormone. This makes them retain free water like a sponge. So if you give them hypotonic fluids, even ones that seem harmless, their sodium can plummet dangerously fast.
So what's the recommendation?
It's a major shift. Use isotonic IV solutions with physiological sodium of about 140. Add just a little glucose, maybe 1 to 2.5%. And post-operatively, because ADH is still high, you often restrict their maintenance fluids to maybe 50 to 70% of the calculated rate.
What an incredible summary. I mean, the core takeaway here is that fluid management is totally transformed. We're moving away from these arbitrary volume protocols.
Right.
And toward this highly personalized, dynamic, goal-directed therapy, viewing fluids as drugs with dangerous side effects.
Absolutely. And, looking to the future, the research is pushing even deeper.
Like what?
Well, consider the novel approach of using high-dose vitamin C in burn resuscitation.
Vitamin C.
Yeah. It acts as a powerful free radical scavenger. It seems to stabilize the damaged endothelium, and it's been shown to significantly reduce the amount of fluid needed in the first 24 hours.
So you're treating the cause of the leak, not just chasing the deficit.
Exactly. It's molecular resuscitation.
That is a fascinating thought to carry forward. But for now, let's solidify what we've covered today with a practical challenge for you, our listener.
Okay. Practical application challenge. Imagine you're managing a high-risk surgical patient. You're using a goal-directed protocol with an arterial line. You just gave a 250 ml fluid bolus.
Okay.
You check your monitor. The patient's PPV is at 6%, well below the threshold for fluid responsiveness, and their cardiac output has barely budged. It's up less than 5%.
Their mean arterial pressure, their MAP, is low. It's 60, and your target is 65.
So, based on everything we've discussed, what is your next immediate clinical step? More fluid or something else?
What should you do and why?
The key here is that the low PPC and the tiny CO response are screaming that this patient is on the flat part of their Starling curve. They are not fluid responsive.
Right.
So giving more fluid is just going to lead to edema. It won't efficiently raise their pressure or their cardiac output.
So the evidence dictates that the next step should be to start a vasopressor, like norepinephrine.
Precisely. Vasopressors are much more efficient at raising the MAP and improving tissue perfusion when a patient is already normovolemic or non-responsive, but still hypotensive.
You avoid the harm of fluid overload by targeting the pressure directly.
You got it. Thank you for joining us for this crucial deep dive. It's a field that is constantly evolving.
Stay well informed, and we'll catch you on the next deep dive.